an entire suite to do the pre-operative consults. So you can, you can do IOL calculation, topography, specular microscopy, lensometer, and all this. The students are immersed in that. We have this we call the hybrid classroom, that people can, practice just basic skills with artificial eyes. Our refractive suit that they were showing, you have another one in that amazing hospital, but we have one specifically, and is one of the few in the world specifically done to teach and to learn. This is everything is happening in Mexico City, and that's our best, look at that, look at all that technology. And that technology is surrounded with a nice methodology. So all the colleagues around Latin America can become surgeons in a very fast and efficient way. So we wanted to say that from Ophthalmo University, and we wanted to show everybody that there is a lot of possibilities to become a surgeon. And we want to say hi and we say thank you to one brother of us, that is Dr. Takashi, that is always behind innovation and trying to do these amazing events where we have only one objective today, and that objective is to transfer knowledge and transfer skills, but especially to add value to your time. This is important. Nobody here who is with us has enough time. We know that. So what we want is to give you tools to add value to it and be more efficient and to enjoy more. As you can see there, today we are going to talk a lot about VIVITY, especially. It's a new technology that Brazil has. I'm, for example, in Mexico City. That technology is arriving. So there's so many surgeons here in Mexico who are gonna benefit so much from your experience. So we're gonna be there waiting for you for all the tips in not only how to do the surgery, but how to talk to the patient, how to calculate the IOL, how to manage astigmatism. I think everything is going to be important for us. And again, I'm going to just finish and thank you again, Takashi, with this amazing quote for somebody who wasn't Michael Jordan, as you can see there. It was the trainer of Michael Jordan. And this guy is Tim Grover, and said something, look at the important, it's so important what he said. He says that you are as good as the tool you chosen, and the ability to use them are their maximal potential. So I think today is a clear example in how phacoemulsification surgery has rise to the next level, and we're going to use IOLs. We're changing the paradigm completely. So Takashi, thank you so much for the big effort in doing live surgery with that amazing team you have behind there. We also have Professor Pinera with us today, doing some comments. So today is a happy day. So thank you, Takashi, and we're all here for you.
Well, thank you, everybody. So I would like to introduce here Guido. Guido is our host, head and owner of the Hinsema Hospital.
Hello, everyone. We are going to have a great time today and a nice surgery with Dr. Liangi. We are preparing everything here. There, come in here.
Hello, everyone. Good evening.
This is
How are you?
Liangi. He's going to perform the surgery today.
Let me show
Congratulations to be as confident to do, live surgery like this.
Okay, so let's introduce Aline. Aline, please. So Aline is going to start the lecture here about...
Good night, everyone.
Let's go then. So Aline is resident from SEMA. She's going to share about the VIVITY.
And non-diffractive wavefront IOL.
Just a second. To align the speaks here. Just a second.
We will start remembering the evolution of modern IOL technology.
You're mute. You're mute. We can't hear you.
diffractive wavefront IOL. That last one is our matter, VIVITY. There are clinical effectiveness criteria for each of IOLs. That was a statement by American Academy of Ophthalmology Task Force consensus to provide the evaluation of implant performance, minimum performance levels based on defocus, curve testing methodology, and lighting conditions. Implementation of these recommendations provided more objective data for FDA. This is VIVITY IOL. The VIVITY IOL X-wave technology is made up of two smooth surface transition elements in the central 2.2 millimeters of the IOL. The first is a slightly elevated smooth plateau that is about 1 micron thick. The second is a slight curvature change. The slightly elevated smooth plateau is responsible to stretch the focal range. The small curvature change is responsible for shifting the continual extended focal range to the anterior side of the retina. This way, a full range of vision is provided to the patient. So, VIVITY IOL uses patented non-diffractive X-wave technology to stretch and shift the light wavefront, giving an extended deeper focus. These data are from two large prospective multi-center randomized controlled clinical studies of bilateral implantation of Acrisoft IQ VIVITY IOL versus the control Acrisoft IQ monofocal, one within the United States, FDA, and the other conducted in multiple countries outside. Unlike diffractive technology, it does not split light. This means it can utilize almost all the light like a monofocal and hence has an aspheric monofocal visual disturbance profile, while the uniform light intensity distribution gives more natural vision. One of the main reasons for surgeons not performing presbyopic IOL procedures is the concern over postoperative quality of vision. The ASCRS survey also reported that the most frequent complaint leading to explantation of one-piece hydrophobic acrylic multifocal IOLs is the glare and optical aberration, plus than 90%. VIVITY lens has the ability to provide a broader range of vision than a monofocal and similar visual disturbances. So, we resolve the problem and save time and effort with both pre- and post-operative counseling, since the risk for visual dysphotopsia is not different than a monofocal. We can exemplify that at the image using optical branch data of pinhole images to simulate halo effects. At monocular test was observed clinically meaningful drop by ISO standards, and with binocular test, that drop wasn't maintained. At this time of life and presentation, what all of you want to know is, what could I tell to my patients before the prescription? Based on my expert advisors, first, you must schedule enough time to counseling and receive well the patients. Second, be polite and respectful with patient demands at the same time that you show your capacitation in cataract and premium IOL. Third, try to keep updated about the new technologies. Fourth, make clear that not only all the patients has the ideal conditions to put a premium IOL, and your decision takes care the eligible criteria. Fifth, analyze with care the data and make clear to the patient that the presented options ideal free and presented by yourself are specifically to him. More about that? Me and Dr. Natalia made a manual of good practices that another time we could present to you. VIVITY X-Wave technology provides excellent distance and intermediate vision with good functional near vision in both bright and dim light conditions. Is also good for active lifestyles, presbyopia correction, and for those who prefer use glasses to read at close instead higher risk of dysphotopsia. So, would you consider using VIVIT in patients with a non-pristine eye? Probably. For example, for pediatric cataract above 7 years old after radial keratoplasty, for age-related macular degeneration early stage, for moderate to severe dry eye, mild to moderate keratoconus with small astigmatism, for epiretinal membrane, cellophane light reflects with good visual function at this case, and for subluxated crystalline, mild corneal opacity, and after intrastromal corneal rings. And which patient characteristics should be avoided and what are general exclusion criteria? Demand of a good vision for all distances without glasses, high grade of vision expectations, insecurity about lens choice, moderate to severe alterations in ocular surface and macula too. That's it. Thank you for your time. Thanks a lot.
Okay, guys, let's start the presentation of the case. Dr. Maíra was here. Maíra's fellowship, she's a fellowship from cataract from HOB in Brasilia, and she's gonna be presenting the case. Maíra.
Our patient is a 69 years old, Caucasian female, complains of blurred vision, and there are no reports of trauma or previous eye surgery. At ophthalmological examination, she presents uncorrected visual acuity in the right eye of 20/30 and in the left eye of 20/60, with no improvement after refraction. At previous pathological history, patient reports having hypertension and diabetes. The biomicroscopy exam shows cataract in both eyes, nuclear opalescence 2 crosses and 6, according to the LOX 3 system classification. There are no other pathologies or abnormalities. For the calculation of the intraocular lens, the following exams were used. The specular microscopy is normal in both eyes. In the topography exam, we observe regular astigmatism with the rule in right eye, and we observe regular astigmatism with the rule in left eye. In the scan of both eyes was observed the same pattern of optical aberrations of the topography. Also, there are no alterations at the posterior curvature map. In this image, we observe the retinography of the right eye without change, and the retinography of the left eye also does not present alterations. The biometry of the left eye, which will be operated, evidences normal values. After evaluating the biometric data, an outcome calculator was used, resulting in the indication of a toric intraocular lens, 20.5 DFT 315. And now, let's watch the live surgery.
Empezaremos la cirugía al vivo.
Hi everyone. Are you listening
Hola.
to me?
¿Puede escuchar?
Hello, testing, listening.
Yes, we're listening. Hi, Dr. Pineda. What an honor to have you here with us.
This is Liang here.
We can hear perfectly.
We can hear you, Liang.
All right, I'm listening. Yeah. Dr. Pineda, how are you?
Very good. Thank you for the invitation.
Thank you. So I think that Mayra has already presented the case, and the plan is to perform the phaco emulsification and to implant a VIVITY toric IOL. So everything is all set here, okay? And the ocular the pattern is already being registered. So probably, as you can see, there are two marks here. This is the variant, okay? The outcome system to guide the surgeon for a toric surgery, toric incision. Oh, okay. So Takashi is going to show you what I am seeing in in the microscope. So you can there's a green ring, and if you can take a look at 135 degrees here on the right side, and something like 20 degrees on the left side. These places, these sites are the incision sites. Okay, so I'm going to perform a simultaneous incisions using the keratomes. So here at 20, and here at 130, 140. This is a 2.4 keratome. After the incisions, now I'm going to inject the viscoelastic. This is a dispersive viscoelastic. It's the viscoat. It's a dispersive. I want to protect endothelium and maintain or deepen the anterior chamber. Next step is to perform the capsulorhexis. So I'm going to use my forceps. It's a crossed forceps, and I'm going to tear the anterior capsule with the forceps. So I'm going to tear and make the flap. Going to perform tangential movements in order to, now this is the capsulorhexis, the rule, okay? So I'm going to tear tangential movements. It doesn't matter how many grabs the surgeon has to grab, as long as the capsulorhexis end up in a curvilinear or at the best scenario in a round shape. So after the capsulorhexis, now I'm going to perform the hydrodissection and hydrodelineation. I'm going to remove a little bit of the viscoelastic just to give more room for the BSS, the saline solution, to enter the eye. And now, not at the 90 degrees, but oblique. And I'm going to inject. At one point, at the other point, sometimes I'm going to push the nucleus to make the BSS to capsular bag. And I am using the cannula to perform the nucleus rotation. If anyone wants to make any comments, ask me some questions, please be free to do that. There's no need to wait until the end we can talk about the surgical steps if you want to, okay?
I just would like to add that you make it look so easy that it's not fair.
It's not easy. It's it's something that
no, it's not.
So the nucleus is loose inside the capsular bag. The anterior chamber is full of dispersive viscoelastic, the viscoat, okay? I want to, at this moment, I want to thank SEMA, Dr. Guido Aquino Jr., all the staff, the medical staff, the nursing staff, and the Alcon staff. They are all here to help me. So I'm very lucky to have everybody here. Thank you very much. So now there is the phacoemulsification itself. So I like to use this instrument. That's a Y-shaped instrument. It's my practice since the beginning of my my surgical my surgical practice. So I think that's comfortable to me. Let me talk about the parameters. So I'm going to use, this is the Centurion, Alcon Centurion. It's a peristaltic balm, peristaltic machine device. I'm going to use only torsional ultrasound. It's 70% of ultrasound. The infusion is active. It's controlled by the machine. So it's 65 millimeters of mercury, 450 of vacuum, and the aspiration, the flow is 45. The technique that I chose today is the phaco chop. Okay, so not making any sculptures. Let's wash the surface a little bit, entering always irrigating to avoid to enter any air bubbles. I want to know if the image is centered, it's focused. So please tell me, I can adjust
perfect.
Here.
It's perfect, it's perfect.
Okay, so I am aspirating now the cortical material, the anterior cortical material, just to show me, just to present the nuclear part. The nucleus is kind of soft. I can separate using the instrument the nuclear part from the epinuclear part. It's so soft. I think I'll have to split with the instrument. So this is the nuclear part. I'm going to try to make the eye to be fixed in the primary position. Basically, it's a very, very soft, very low the consistency is very, very low, very soft nucleus. And this is basically the emulsification part. So the bag is always, it's almost empty. There is only the cortical material. So I'm going to refill the anterior chamber and the capsular bag. I want to stretch the capsular bag in order to perform the irrigation aspiration of the cortical material that it's on the capsular bag wall. The technique to perform the irrigation aspiration is the hurricane technique. developed and described by some Brazilian surgeons. I think that Takashi was part of the team. When the cortical material is concentrated mainly next to the main incision, it is, I think it's a good idea to change the port to aspirate. So let's change it. I'm going to irrigate the main incision and aspirate by the side port. Ivo, Dr. Pinera, and everybody, please make our comments. I'm totally open to your words, to your thoughts.
Dr. Liang, I want to ask you, what's it's that instrument, Y-shaped instrument called?
I keep asking me for the last 20 years because, you know, when I was a third-year resident, I saw a Venezuelan surgeon in São Paulo called Ángel Pineda, also Pineda. He was the Paulista Medical School fellow some years before, and he performed this the live surgery, and he was using this instrument, and I thought that it was a good idea because back in the time all of us used to perform the surgery all alone without any assistant, without any other resident. So I had to keep my set, the table, as clean as possible. So I never liked the sets with many instruments. So I wanted to use one instrument for all, to rotate the nucleus, to chop, and to rotate the IOL. So I think that it was I was very happy. So I asked the people that make instruments to produce for me this, I don't know the name. So now this is the VIVITY, okay? This new lens from Alcon. It's a 2.4 wide incision, and I'm going to insert the lens now. I'm going to center the eye. And then this is mouth to mouth. There is no need to go all the way inside the anterior chamber. Make a little bit of pressure just to let the lens inside go inside the anterior chamber, and then I can let it a little bit loose. So everything is in the eye. I can use the own system to make sure that everything is in the capsule bag. Now let's.
Just a quick, first to congratulate you for the capsular rexis. I think it's very, very nice, and especially the size. And the second thing is how important it is for you to polish the entire capsule while you're implanting a technology like VIVITY.
Yeah, thank you. Thank you for the capsule rexis. I tried to make a round, a circular one, but this one a little. It's okay. The capsular posterior capsular polishing is it's an important part. But I think that during the surgery, it's possible, it's easy for a surgeon to watch, to see, to analyze the posterior capsule status, because if everything is loose and during the irrigation aspiration of the cortical material, everything has come out, so I can assume that the posterior capsule is clean, it's free of epithelial cells, and everything is going to be okay. One important point is to see, to analyze the inner part the anterior capsule also. So sometimes there are some debris from the cells that have to be removed. So now
another quick question: what about the centration of VIVITY? Is it important to have a perfect centration because of the technology?
So my apologies. They're going to show the position is not it's not in the right position of the toric part. Okay, I'm going to answer what you have asked. The central part of VIVITY has to be of course at the central part at the center of the visual axis. This centration, the IO centration, most of the times depends on the capsular bag integrity. So of course, every surgeon wants the capsular axis to be round, to be centered. Okay, so you are watching the rule. Okay, so the ruler. So this is the position that the lens has to be, and I'll show you where is the toric part of the lens, and I will zoom it. So what I think is, if the capsular bag is okay, it keeps the integrity. If the capsular axis is centered or nearly centered, the IOL, in this case the VIVITY, will be centered, and the inner part, the rings of the lens, will be also in the center part, in the visual axis. It is important because the extended depth of focus that VIVITY wants to provide to the eye, this extended depth of focus is produced by this central part of the lens. If it's not centered, if it's not perfectly centered, there is a high risk or chance for the eye not to have this extended depth of focus effect. So this is probably the same concern that the surgeon must have when is implanting any other lens that's a diffractive lens or any other refractive not monofocal lens. So I'm going to zoom in it just to show everybody the let me here. I don't know if you can see the 3 dots here and 3 dots here. They are aligned with this line here at 85 degrees. Can you see it?
So Dr. Liang, I have a question. So if you don't have access to a digital marker like the Varian, how do you typically mark your patients for toric?
There are some resources. Slit lamp is a good choice. If there isn't any slit lamp in the OR, there are those markers with pendulum. The pendulum only marks at 3 and 9 o'clock. That is 180 degrees. If the surgeon chooses to use the pendulum, there is a need to use a ring, 360 ring, to guide the surgeon to look for or to find out the 135 and the 20 degree sites of the incision. I myself, in my private practice, I use a device called Robo marker. A Robo marker, the Robo marker is a marker that is not pendulum, not gravitational device, and I can rotate the marker so the incision site and the toric site, the toric part, the position of the lens can be marked outside just before the surgery. I can show you in the next opportunity because it saves some time. It's good. It's I made some comparisons before I started to adopt this technology or this resource, so I could use it just before the surgery and not depend on it during the surgery. And the marks are so strong that they keep the paint that with the Robo marker. They are so strong that sometimes at the next day, on the first post-operative day, the marks are still in the limbus.
Mm. Yeah, I use when we sometimes use a manual marker, and then use a telephone app called ToriCam by Graham Barrett to verify how far our manual marks are off to compensate, which we find useful.
Yeah, there are some mark some apps for this purpose. The lens has to rotate a little bit. I have to reposition it. You see that they rotated something like 10 degrees. I have to put in the position again. So I'll put the dispersive viscoelastic again. Okay, it has rotated, so I have to fix it. No problem. I'll put a little bit inside the bag just to allow me to rotate. All right. So I don't know if you are watching the ruler. So the lens has the toric part. It has to be here, and the lens actually is here. So I have to rotate, and the rotation is always clockwise. All right. This is something that the cataract surgeon that starts implanting toric lenses has to consider that sometimes has to rotate because it goes out from the original or the right side, right angle, right position. So it's back again.
Dr. Young.
Yeah.
Since we are talking a lot about astigmatism and the toric IOL, what is your mindset with the VIVITY IOL? What I mean is, for example, with panoptics, I'm completely obsessed with astigmatism. I want that patient in zeros all the time. Do you have the same mindset for VIVITY that panoptics?
Yes. I am completely obsessed with correcting astigmatism, even with the monofocal IOL also. We want to, I think that all of us, we want to provide the patient, provide a good vision, a good far vision, intermediate vision, and why not to provide a good or satisfactory near vision also, depending on the patient's needs. So my mindset is to correct the astigmatism above 0.9 diopters of astigmatism. If the eye has less than 0.9 astigmatism, I can consider to look for the steepest meridian and to make the incision at the steepest axis. But more than 0.9, I think that we have to consider the toric IOL.
Perfect. And there is a couple of questions from the public I don't want to miss. They're asking about experience. If you have one eye that has been operated already with a monofocal, would you be able to put a VIVITY in the other eye? Maybe Dr. Pineda can also answer his experience. I don't know if you already have VIVITY in the US.
Yes, we have the VIVITY since last year. It was released last fall. I've been using it for the past 6 months. And I've definitely placed the lens in several patients who have had a monofocal, standard monofocal lens in one eye, but would like, better intermediate vision in the other eye while maintaining good distance vision. And the VIVITY has been a great choice for them. They were only sad that they didn't have VIVITY in the other eye. So I think this is an excellent patient to consider using the VIVITY because it will usually be provide good binocular vision for the patient with improved intermediate vision.
I myself, I shared the same opinion of Dr. Pineda. There are some patients at the Federal University of São Paulo that are already pseudophakic in one eye, and we chose to operate and to implant VIVITY in the second eye, and they started to say that depending on the needs, they don't need to use glasses for near vision anymore. So it's a good idea. And I think that the combination, this combination of monofocal in one eye and VIVITY in another eye, either if there is a toric or not, but to correct everything and keep them working together, I think it's a good choice.
There is also other two very interesting questions. One about the requirements for multifocality.
Well, the requirements for
the same way as a panoptics, the kappa angle, the pupil. What do you think about that?
Dr. Pineda, do you want to make some comments about that before?
I mean, in respect to VIVITY, I think this is always, it's a good question. You're essentially needing to do a refractive evaluation for these cataract patients, meaning that you do need to measure the, mesopic pupil size when you're talking to patients, because obviously with some of the diffractive optics, this is going to matter. In general, patients, you don't want patients to, if they have very small pupils, they're going to have a pinhole effect that might augment the benefits of VIVITY. I've not really experienced that with this lens, but I think that's important. And obviously a patient with very large angle kappas, what they already mentioned here in the chat of usually more than 0.5, that can be potentially an issue, particularly if the VIVITY, even though it has a large central area, if it's 2D centered, it can be a problem. But I think we have to congratulate Dr. Liang on his successful cataract surgery.
Excellent. Another couple of questions. The first is if you measure white to white, are you using CTR depending on the white to white? A capsular tension ring if you have a big white to white.
Yeah, or a long axial length, a high axial length. Do we modify that? Or does anyone have an algorithm that they use?
Yeah, about the CTR. If there is a chance for the lens to be unstable or to disintegrate, depending on the white-to-white measurement, it is a good idea to have a CTR in the OR if is necessary. I've never, to be very honest, I've never used the CTR in those cases of big eye, large eyes, large capsular bag measurement. So, but it is a resource. It's something that it can be done.
Another question, what about, Dr. Pineda, what about a mix and match between an optics in one eye and VIVITY in the other one?
Yeah, so I think that potentially could be a good combination for patients. I think this, requires a good conversation with the patient about what the expectations are going to be. I mean, obviously the PanOptix as a diffractive optics is going to be more sensitive to, since there is some splitting of light or dividing of light, that in dimmer situations, maybe the near vision might not be as good. But as long as the patient understands that, or if they, have a personality maybe where they're not going to tolerate halo and glare, particularly if they're at night, night driving, you may not want to consider the PanOptic in those situations for the patients. But again, I think what's important here is a careful discussion with the patient about what the expectations are, so that, the patient understands that before they have the surgery, and that they don't come to you after the surgery with complaints. So I like to take the time up front to speak to the patient about these issues. It's much easier to talk to them about it before the surgery than after the surgery.
I agree 150% with Dr. Pinera, since we're talking about two technologies, one diffractive with all the benefits and with all the side effects of diffractive lenses, and the other eye with not diffractive but refractive with the benefits, with the contrast sensitivity different from these diffractive lenses. So I think that chair time is the key. So we have to talk, to listen to the patient and see if the patient is too demanding, it's too easygoing, depending on the personality of the patient. But yeah, the positive dysphotopsias they have to be considered in the preoperative chair time.
Yeah, I think Dr. Liang, you bring up an important point. These lenses can also create positive and negative dysphotopsias for patients as well, and that doesn't go away with these types of lenses. So I think we're still trying to understand all the risk factors for patients developing these visual symptoms after surgery. But again, I think spending time to figure out the person's personality and what they think they want versus what they should get is very different. So can sometimes
managing expectations, right? That's the key. Managing patients' expectations. I agree 100% too.
That's it. There is a if you allow me, there is a question that I'm seeing here on the chat. Does it have the same glistening rate as the other IQ? It's something that we don't know, because they are all I think that the PanOptix and the VIVITY, they belong to the same platform. That's Microsoft. So I don't know. I hope sincerely that there won't be any glistening over the years from now. That's something that we have to wait and to watch the lens behavior. I don't know, Dr. Pinera.
I mean, I think they made modifications, several years ago to the molding process to reduce the incidence of glistening. So, but, I think that's still a question. I don't know. I agree with you that the platform is similar. There may be something slightly different with VIVITY, but I think we have to wait and see. Hopefully all of this will be switched over to Clarion material in the future, where we don't have to worry about these long-term glistenings. I hate looking at patients I did 15 years ago, and they're complaining, about the contrast. And we know it's, from the glistenings, especially the older Acrosoft models.
So Dr. Pineda, since you told us that you are using the technology for the last 6 months, tell us a little bit about your mindset or your workflow when you have a patient, when PanOptix and when VIVITY. I think everybody's asking that.
Yeah, so, I think the patients in Boston, many of them are, they're fairly well educated. So they usually come in having already researched a little bit the lens choices. So, I always ask patients to kind of tell me what they're doing, how they're spending their time, what their visual priority is. So I use the term visual priority. So, is distance most important? Is reading most important? So I can kind of help direct their choices. Obviously, we get a full kind of panel of different testing beyond biometry. We get topography on everyone. We get specular microscopy. So once we have all of this information to determine their reasonable candidates, getting to the choice between VIVITY and PanOptix really comes down to me about a question of how important their reading is without glasses. So if they say I have to be able to read without glasses, then I more focused a little bit on the VIVITY. If they're happy to say, I just want to be able to go into the store, see the price tags on the store. If I need to, I call it glancing vision, meaning for near vision. You can pick up a piece of paper and kind of read it, but you're not going to sit and read a book for an hour with the VIVITY lenses. So I find actually most of the time, most patients are very comfortable having weak reading glasses for if they're going to do serious reading. They just want to kind of live their life though without having to need it for everything. And so I've actually drifted, I would say, a little more toward VIVITY over PanOptix. And when I had an anesthesiologist in this afternoon who we had this very discussion about, and he said, I need to be able to read my journals. I need to be able to do my reviews. And so we ended up choosing PanOptix for him over VIVITY. And we had a long, nice discussion about that. So to me, the differential is mostly around how important reading is to those patients. So I don't know what your experience is, but that's kind of.
No, we are waiting. We still don't have it in Mexico, and I'm trying to learn everything. Okay. I'm like a sponge, trying to learn everything. But here goes a very, very interesting question, Dr. Pinera. What about yourself? If you had to have surgery tomorrow, which lens would you choose for yourself?
That's an excellent question. So I think, I like the extended depth of focus. I'm a technology in general. I think these platforms, I don't like the idea of splitting up the light too much. I don't mind a little bit of loss of light, but too much I think is problematic. And I think I could be comfortable with reading glasses for small print. So I'd probably end up choosing the VIVITY over the PanOptix just for that reason alone. And I like the idea of maybe having fewer halo and glare as well. I'm a perfectionist in maybe taking care of patients, but I don't think I'm a perfectionist with my own vision. I'm a little, actually right now I don't use reading glasses. I'm 58 And I'm a little myopic and I have a little bit of astigmatism, and I'm happy with 20/25 distance vision, so I don't need to wear glasses up close.
Very good. What about the rest of the panel? Because we have Mayra, we have many other surgeons. What about them biometric formulas, you know, the refractive target? Let's talk a little bit about that. There's many people asking about that.
Anyone? I mean, I personally use the Barrett Universal 2. You know, we have Aura available, which we do for a lot of our premium lenses. And for VIVITY, I usually, if I'm doing both eyes, I'll target one eye for plano to -1/4, and the second eye I target for like a -1/2. You don't want to go too myopic with VIVITY because it tends to create more optical aberrations for the patient. So we just do a whatever nano vision, as someone like to call it, just a mild difference in refractive targets between the two lenses.
But sorry, but
I can't hear you.
Am I back? Sorry.
Yes.
Oh, no, but you said something very important. You said not to go for myopia, because there's
not too much. Like, don't aim for -1 with a VIVITY lens.
Okay, I will put some, you know, in the non-dominant. I will put an extra myo. Oh, that's a very good concept.
Yes. So just you know, kind of plano -1/4 in the dominant eye, and I don't go more than -1/2 with the non-dominant eye.
Dr. Pinera, what happens if the eyes? I'm asking because I don't have much experience with that. What happens with the intermediate and near vision in an eye with VIVITY if the eye is more than half diopter, -1/2 diopter?
So I mean, so they can see better up close.
Yeah.
But I think the optics of the lens tends to create more like distant visual symptoms. Okay. I mean, I actually had one patient I needed to exchange the VIVITY on. There was basically a translation error, and so we ended up putting a VIVITY in that ended up making the patient -175. I mean, she could see J1 plus, but you know, she had other optical aberrations, and you know, we ended up exchanging that VIVITY for another lens. But you know, there's, I guess, my understanding from what I've been told is that there's an increase in optical aberrations once you get beyond a certain point. So they don't really recommend going much beyond -1/2 for the maximum myopic target for the VIVITY lens.
So the idea is to, if there is a case to implant bilaterally VIVITY, so the best case, the best scenario is to make both eyes, to plan both eyes to plano and or slightly myopic.
So I mean, I think the idea is to give people a little bit more near vision by going just a little bit myopic on the target. And you know, so that you can get those patients maybe better than 20/40. You can get them to maybe 20/30, or the best patient I've had is 20/25 at close. But 20/40 is pretty common. J3 for us, our terminology, but
no.
Most patients, they meet their expectations, you know, with the target of 20/40 at near.
Here at SEMA, Guido was telling me that there are 30 patients. 30 patients. Almost 30 patients. Everyone with the biometric calculations to plano, and they reached 20. How much? 2020? 2020. Jagger 2. Yeah, Jagger 2.
Yes. So Jagger 2 is not uncommon Jagger 3, I would say, is more common, and occasionally we have people Jagger 1. So, but I tell people Jagger 3 is what they should expect. At max, you know, that's the average.
I want to, since you're talking about Guido, I want to thank him very much for this opportunity. He is the magician behind the scenes, you know, allowing us to do this surgery in their amazing hospital. Thank you so much, Guido. And just for matters of time, I know, Dr. Pineda, you're very busy, but we have Dr. Patricio Lopez, very, very, you know, on fire today with amazing questions. And he's asking if you have a patient with a Fox endothelium corneal dystrophy, and you're planning to do a DMEC and offer multifocality, would you implant a VIVITY in that case?
Are you asking me?
Yes.
I think, yeah, I mean, I think I wouldn't do it with a DSEC case. I would maybe use DMEC just because the refractive targeting is a little more predictable. I think DMEC, the endpoints are a little wider. But you usually have to compensate for half a diopter of hyperopic shift with DMEC. It also depends on how severe the Fuchs dystrophy is. So in severe cases, I would not. In cases that have mild edema, where endothelial keratoplasty is indicated, and you're doing DMEC, I would consider a VIVITY in that case, but certainly not in all cases. But in those cases, I would.
Amazing, amazing answers. Thank you so much, Dr. Pineda, and thank everybody. I think this was amazing. 1 hour, a lot of knowledge. People go with a lot of knowledge. So thank you very much to everybody, and hope to do this again. Hope Guido is kind with us and we can do this every week.
Thank you, Ivo. Thank you, Dr. Pineda.
Yes.
I'd like to thank everyone for the effort to make this event happen. And Dr. Liang, Dr. Takashi, our anesthesiologist, Dr. Raul, and Aline is here, and everybody. Thank you, Maíra. Thank you, Ivo. See you soon.
Thank you, guys. You're amazing. Hope to see you soon.
Thank you, Ivo. Bye-bye. Bye-bye.